Good morning, everyone. Welcome to the critical care for the COVID-19 patient. We're really happy to see everybody today. Just a couple of housekeeping announcements before I turn it over to our fearless leader, Michelle Harkins. We love to see people's faces, so if you have a camera and you can turn it on, we would love to see your face. And we always bug people about that, and most of you who know us already know this already. Also, if you have any questions during the presentation, please put them into the chat and we'll try to get to all the questions that people have. And we would ask that that people refrain from actually answering the questions in the chat if they're directed toward the hub team. A couple of other things that we'll have a CME will be put into the chat at about 45 minutes after the hour if people would want CME, and we would like to hear your feedback as well. We also have a digital librarian, Bonnie, today, who is going to be helping us and putting things into the chat, resources. So please pay attention to that as well. So without further ado, I'm going to turn it over to Michelle Harkins to introduce our guest.
Thank you, Dr. Thornton. Good morning.
Sorry, Michelle. I forgot to introduce myself.
I was going to do that for you.
Carla Thornton, one of the infectious diseases physicians at UNM and Associate Director of Project ECHO. Thank you. Sorry about that.
No worries. Thank you, Dr. Thornton. Good morning. I'm Michelle Harkins, Chief of Pulmonary Critical Care Sleep Medicine, and welcome to another session of the Critical Care for the COVID-19 Patient. It's great to see you this morning, and thanks for joining us. We are really honored today to have a guest speaker, Dr. Martha Muller. Some of you had actually specifically questioned, COVID-19 in pediatrics, and while that is not my realm, I have invited my counterpart, Dr. Martha Muller, to give us an update on this. Dr. Muller is a professor of pediatrics at University of New Mexico. She's the division chief of pediatric infectious disease and the interim division chief of pediatric pulmonary. And so we kind of switched roles that way. In the past, I was pulmonary and critical care chief of adult and interim ID chief for a period of time of adult ID. So she's my exact counterpart, and we're really lucky to have her come talk to us about COVID-19 in children. So with that, Dr. Muller, please take it away.
Good morning. Thank you so much for allowing me to come and spend a little time with everybody this morning to talk a little bit about COVID-19 in the pediatric world. We love our babies, and certainly as we go through this, you'll see we have seen a little bit of a different experience than you all, probably most of you all have as adults. We're gonna briefly discuss pediatric COVID-19, look a little bit at epidemiology, presentation, and symptoms, and talk a touch about just our management of COVID-19 in the pediatric world. And then we'll spend a little more time talking about multisystem inflammatory syndrome in children, or MIS-C. And this is, by and large, at least right now, anecdotally, what we are tending to see a little more of in the hospital from the pediatric world as it relates to SARS-CoV-2, at least for us here at UNM, and then have a couple of slides to talk about the COVID-19 vaccinations in the 12 to 15-year-olds, because that's a big deal for us, right? So, I think everybody clearly knows this timeline, right? Everything, this Sentinel event back in December of 2019 with the unusual viral pneumonias, and over the next 3 months, the renaming of the virus to the current nomenclature of severe acute respiratory syndrome. I'm going to put this down here for a minute. Syndrome, coronavirus 2, or SARS-CoV-2, and then the disease, COVID-19, and then the fact that we went into pandemic mode in March of 2020, and everything kind of shut down, so to speak, at least for us. And certainly, as you all did in the adult world, in the pediatric world, we started as we entered this pandemic and started to move through this pandemic. started to think, what is this going to mean for our children? You know, what do we need to do? How are we supposed to be managing this? And, you know, the old adage that kiddos are not just little adults really is very true. And, you know, for this particular pandemic, the lens that we look through, we have to realize that some things are going to skew that a little bit, and we're going to have to take that into account as we are considering our children and the way they present and the way we manage them. There is, you know, this is definitely better this far into the pandemic, but over time and throughout the pandemic, we certainly have had a lack of widespread testing in the pediatric world. The kiddos were not the priority, certainly the adults, because they were the population that was getting the sickest. They were the priorities, and there was a priority for testing for severe or symptomatic disease. And from our standpoint, many of our kids don't present that way. We'll have a couple of slides in where we see the kiddos, they generally aren't coming in with severe disease. So if the priority is for symptomatic testing, we're going to miss quite a few kids that way. Very early on in the pandemic, some of the social arena, school, sports, all of those, they were shut down for our kiddos. And so what does that mean for our transmission? This will be interesting as we start to open things up again. The kiddos are now slowly but surely heading back to school. I think this will be an interesting time for us. But throughout the pandemic, there's always been this question of, okay, well, we kind of did some mitigation strategies that probably changed that epidemiology a little bit, and what will happen once we re-enter those same things. And then people don't necessarily tend to count cases and case fatality the same. And so we have some heterogeneity in those reporting. So all of that makes it not, impossible, but, we have to consider all of that when we are working through what's going on with this in our kiddos. Now, that said, certainly there are some things that are the same when we look at the experience between peds and adults. The incubation period, all of that appears to be the same between the adult and pediatric world. Many of the signs and symptoms of the disease are the same, even if they're not necessarily demonstrated to the same degree. So I think certainly the adults sometimes tend to present a little different than our kiddos, and we've got a slide where we'll talk about how our kiddos tend to present. But children, will potentially have not the best outcomes and go on to experience some of those outcomes like multi-organ system failure and coagulopathy that maybe in the adult world you are a little more used to seeing. This slide really gets into the epidemiology and starts to kind of pictorially show us the difference that we tend to see in pediatric COVID-19 compared to adult COVID-19. This is a slide from the CDC with very recent data of cases of COVID-19. And the gray bar here represents the population, and then the maroon bar represents the cases. And what we can clearly see here is that the pediatric cases are not representative of their contribution to the population at large, which is very different clearly than what we see in the adult world. So we don't see as many of the cases as we have kiddos in the population. And this is New Mexico data where we can see that in our older kiddos tend to drive our pediatric case rates, right? So in our older kiddos are going to be a little more like the adult world in their physiology. So they are the group that we tend to see driving the cases in the pediatric world. This slide shows us again when we are thinking about symptoms by age group in the pediatric world. So, I think you all have the same sort of situation with like geriatrics and kind of your middle-aged and your young adults. And we clearly have a spectrum of ages in peds, and our adolescents tend to be more symptomatic than our younger kiddos. So again, they are the ones that tend to drive the cases. They're going to be symptomatic and likely to be tested a little more frequently. Thankfully, mortality is very low for us in the pediatric world. And I don't say that lightly, recognizing that that is not necessarily clearly the case in the adult world. But here we can see mortality is very low. It has remained low throughout the pandemic. And that has been one of the things that we have really been thankful for in the world of peds. Now, this is something that we clearly have seen worldwide. These are experiences that I just kind of threw in like little wheels to show that not just here in the United States, but poor outcomes in the pediatric world. We just don't tend to see those compared to adults when we are looking at COVID-19 or SARS-CoV-2 infections, I should say, overall. So this is a systematic review by D'Souza et al. And this really drives home the point that our pediatric patients tend to have sorry about that. Less severe disease overall. We can see here that our kids really tend to live in this mild to moderate symptom severity. Again, some asymptomatic patients with a pretty large percentage. Our next slide will actually talk about some studies that give us a higher count of asymptomatic kiddos. But what's really important to see here is that severe and critical illness, we just don't tend to see as much of that in children. Again, unlike what you see in the adult world. And kiddos tend to recover and bounce back fairly quickly. I know that there is the phenomenon of the long haul COVID, and that actually has been described in the pediatric world. And I think that's going to be a stay tuned, and we are definitely learning more about that each day. But by and large, what we have tended to know is that kiddos tend to recover if they were symptomatic to begin with fairly quickly and bounce back without much in the way of lasting symptoms. And so, asymptomatic infection is a big deal in the peds world. Definitely something we continue to think about because, if you're asymptomatic and we don't know that you have the disease, then there's this potential for transmission. And, studies have reported 16% to 50% or so of pediatric COVID-19 infections have been reported as asymptomatic. And so this is, this definitely it influences testing, it influences the way we screen, and considering our social distancing and our strategies, our mitigation strategies. All of that is a big deal when we are thinking about asymptomatic shedding. And recent studies have defined viral loads that seem similar in symptomatic and asymptomatic persons. So I think this is something that we have to continue to look at, and I think it'll be really interesting to look at that as we continue to roll out vaccines. So what do we tend to see with kiddos who have COVID-19? Again, the signs and symptoms are very similar to what we see in the adult world. Fever and cough are the primary symptoms that kiddos tend to come in with if they have active COVID-19 infection. I think it is we should probably mention that in the peds world, I don't know, it'd be interesting to hear from you all, because I don't think that you tend to see the GI symptoms as much, but in the peds world, we often may have kiddos who come in with just GI symptoms, and that's definitely something we'll see here in the next couple of slides when we talk about, or next few slides, I should say, when we talk about MIS-C. But some kids may come in with just the GI symptoms. And so it's important for us in the world of peds to realize that there's a variety of symptoms that the kiddos come in with. Even though fever and cough are the most common, we may see situations where kiddos come in with just diarrhea, nausea, and vomiting, or if they are our little babies, they may come in with poor feeding and instead of fever, hypothermia. Those are things that have been reported, and we have to have a lens on to capture those particular symptoms and think about the possibility of COVID-19 with those. And I will say that, you know, when we think about COVID-19 in kiddos, you know, our experience, at least here at UNM, had been, well, we're really working in this pandemic, of course, to keep our kiddos safe and to take care of our kiddos, but to kind of help the adults. That I think was a common theme around many pediatric settings in the country and probably in the world, I would anticipate, where we were helping to support the adult world because the kids were actually doing very well. And I think we kind of fell into a little bit of complacency in some part of the pandemic, but it's really not an option, even though things are really reassuring, because there are some alarming things. We have noted that hospitalization rates for adolescents aged 12 to 15 years are actually higher for COVID-19 than they were for pandemic 2009 H1N1. And this data from New Mexico clearly indicates, of course, these numbers we have to we have to think about those a little bit just because of the small numbers of hospitalization rate. But the point of the slide here is that our youngest kiddos are the ones that are driving our hospitalizations, and they often can come in and be fairly sick and make their way to the intensive care unit. And so, you know, although we kind of rest and feel somewhat reassured that our kids tend to do very well, there are some situations where we have to think about the potential for more significant disease. That said, breaking news here into the pandemic, as if it wasn't enough with us trying to figure out each day what's the appropriate PPE, and you know, are these kids going to do you know, what we need them to do and stay well. We had the development of this rare syndrome temporarily associated with COVID-19 infections across the world. So not long after the pandemic was was declared in the United Kingdom in April of 2020. They reported a small cohort of 8 kiddos with fever, GI symptoms, shock, and this hyperinflammatory syndrome. And then this slowly spread throughout Europe. Italy reported increased Kawasaki's disease diagnoses with GI symptoms, increased inflammatory markers, cardiac injury being super common. And fast forward to current day, and cases of MIS-C have been reported worldwide. And there are features of this disease that overlap: acute COVID-19, HLH, macrophage activation syndrome, toxic shock syndrome, all of that. That really makes it a little bit difficult for us sometimes as we work through trying to figure out what the pathophysiology is for MIS-C. This is really thought to be a disease that is by and large a post-infectious, post-viral phenomenon, much like kind of a rheumatic fever sort of situation. I think they are still working it out. Some people have proposed maybe there is like a super antigen component to this. There's a dysregulation of the immune system. We really don't know for sure, but certainly there is evidence when we look at epi curves. MIS-C tends to follow when we have a peak in COVID-19 infections in the community. One of the Belay study that we're going to look at here in the next couple of slides, they reported a median time between infection and MIS-C onset of 25 days. And there's been reports of anywhere between 2 and 6 weeks between having your infection, including an asymptomatic infection, and the development of your MIS-C. When we look at MIS-C compared to COVID-19, the kiddos who are presenting with COVID-19 tend to be a little older and have comorbid conditions. And clearly that's an active infection where something like remdesivir for us is going to be employed for treatment, as opposed to MIC, where they tend to be a little bit younger, generally healthy, although obesity has been reported in a subset of those patients. And again, like we were discussing, this tends to be a post-viral phenomenon. The diagnosis can be challenging, right? Because we don't have, it's a syndromic diagnosis without a true gold standard diagnostic that I can do that says, okay, you have MIS-C. It includes non-specific biomarkers to help with that diagnosis that can be abnormal in any of those conditions we talked about in the last slide. There are multiple definitions kind of throughout the world of how people define MIS-C. And again, the pathophysiology is poorly understood. And so putting all of those together makes it a little bit challenging sometimes to fully diagnose MIS-C. The CDC, so the definition that we use here in the United States is the CDC definition, and the AAP, or the American Academy of Pediatrics, utilizes this same definition to diagnose MIS-C. An individual aged less than 21 years who presents with fever, so fever of 38 for greater than an hour, or excuse me, than 24 hours, or subjective fever. So you can, there's room for subjective fever in that as well. Laboratory evidence of inflammation, and then evidence of clinically severe illness requiring hospitalization with multi-system organ involvement, so greater than or equal to 2 organ systems, no alternative plausible diagnoses, and then some evidence of either infection with SARS-CoV-2 or an exposure within the previous 4 weeks prior to the onset of symptoms. And this is the case definition that we use, and you can clearly see that lots of kiddos might fall into this case definition and not really have MIS-C. And so I think this is going to be even more interesting, you know, when we use antibody, SARS-CoV-2 antibody as one of the tests to help us diagnose MIS-C. It'll be very interesting as we move ahead in this world of vaccination to see how we're going to handle that in the case definition. And I will say too, you know, just from a practical standpoint, and for us, one of the, being in a very rural state where many of our kiddos live far out and not very close to medical care, or tertiary medical care, I should say, we have talked with providers, community providers about this, you know, not to be necessarily fooled, I should say, about the illness requiring hospitalization, right? Because the kiddos don't necessarily start requiring hospitalization. And what we have tended to notice, just kind of anecdotally with many of the kiddos that we have managed for MIS-C, is that they can become sick very quickly. And so very close follow-up and with the families, and really empowering the families to contact if they feel, if the kiddos haven't reached a threshold where you would admit them to the hospital, really watching them very closely, because many of these kiddos we have noticed can become sick very quickly, and in a matter of hours transition from the floor to the PICU. So this study by Belay et al. Is a recent study looking at MIS-C during the COVID-19 pandemic, and it's a cross-sectional analysis looking at cases from March 2020 to January 2021. It included a little over 1,700 patients. Again, the kiddos, the median age range was 9 years for those. Interestingly, the male-female ratio very even in the younger kiddos, and then as we increased in age, the predominance changed with a male predominance as they increased in age. Very importantly for us in our state, given our demographics, a little over a third of the cases were Hispanic. Super important to note, just kind of like I was saying with the fact that some of these kiddos could tend to become sick very quickly. 58, almost 60% of these kiddos were admitted to the ICU. And again, very thankfully, as we have seen kind of throughout the pandemic, even with COVID-19, only a small percent of them died. Most of them had involvement of at least 4 organ systems. And, you know, if you can think back to the COVID-19 slide, we said fever and cough were the most common, and that we could see many other symptoms, including some of the GI symptoms, although at a lower rate. Here in MIS-C, a lot of the kiddos, most of the kiddos are coming in with abdominal pain and vomiting. And this is really severe abdominal pain. It's actually put many of the ER physicians and surgeons in a quandary, because the abdominal pain can be so severe that there are concerns that maybe the kiddo has something like appendicitis or like an acute abdomen, given the intensity of the abdominal symptoms. And then very close to that, diarrhea, rash, conjunctival hyperemia, and then a little over a fourth of them come in with cough and shortness of breath. And I have the next slide is actually going to look at an MMWR that kind of hits this group. And I think they probably are a group we should be thinking about a little bit differently. And then with the SARS-CoV-2 evaluation, about half of them actually had positive PCRs. Most of them, at least the ones that were checked for serology, were positive for SARS-CoV-2 serology. Of course, this is always very interesting, right? So this,
did you walk already? Oh, okay. I was going to call.
The PCR positivity is clearly one of the things we use in the setting of infection prevention and control, and helping to guide our isolation and how we manage isolation in the hospital setting. And with these kiddos, this disease is thought to be more post-infectious or post-viral. And even in the setting of positive PCRs, the thought is because of the time between the infection and the onset of MIS-C, that even if we are still procuring virus, that it's probably not infectious or transmissible. I think this is by and large true, except I think in this group of patients, and we're going to talk about this. So this is an MMWR that the CDC put out, looking at a cohort of a little over 500 patients with MIS-C back in August of 2020. And with latent class analysis, they were able to identify 3 kind of classes of patients, which I thought was really great. And, you know, pretty evenly represented here, about a third in each of the classes. This first class, the kiddos, the median age was 9 years old. And these were the kiddos that tended to be the sickest. Oops. They had a high number of organ system involvement. They came in with more of the abdominal pain, the shock, the hypotension that we tend to see, and markedly elevated inflammatory markers. Most of these kiddos were going to be positive have positive serology. Contrast that with class 2, the median age here was 10 years, and these kiddos actually came in with more respiratory symptoms, diagnosed as MIS-C, but more respiratory symptoms. And what they noticed here is that the rate of SARS-CoV-2 PCR positivity without seropositivity was fairly high. And so, you know, of course, the concern with this is, are these kiddos that really actually have more of a subacute COVID-19 infection, and maybe aren't completely fitting into an MIS-C situation. And of course, that would impact your infection prevention and control as well, if we thought maybe they had active respiratory disease. And then this third class, they tended to be younger. And this was the group that actually looked a little more like Kawasaki. So, you know, I think in the beginning, because many of these kids presented with symptoms that were concerning for KD, they were getting diagnosed as KD, but then there were some features that were not completely consistent with KD. And we tend to see with MIS-C, some of the cardiac, for instance, changes, and where we note the abnormalities within the cardiac system are a little bit different. And so This group tended to look a little more like traditional KD, and had 63% or so of them with positive serology only, and then a third of them with serology and PCR positivity. So very interesting with this middle class really being a class that we wonder, is this less MISC and more COVID-19? And I think this will be interesting to see what happens with this as we move through and diagnose more cases of MISC. That said, it's still not overly common. As of May 14th, we in the United States reported to the CDC, they had reported almost 4,000 total cases throughout the pandemic here of MISC, with only 35 deaths associated with that. And then recent data from the New Mexico Department of Health has confirmed 23 cases. So I always like to throw in a plug for infection prevention and control. And this plug really is more geared toward remembering the fact that in the respiratory viral season, we do have other viruses other than COVID-19. This study from Ludvigsen looking at 366 pediatric patients who were hospitalized with respiratory symptoms earlier in the pandemic. Many of them actually had negative COVID-19 testing, but were diagnosed with influenza A or B. And the same has happened with other respiratory pathogens. So, I think this will be interesting as we, again, have started to open up schools and sports, and kiddos are now starting to mix again. This will be something that has to be considered as we move ahead with the ever-changing PPE landscape and how we test and monitor kiddos, and then how we manage them from an infection prevention and control standpoint in the hospital. And then we are going to end with hope on the horizon here. Recently, Pfizer BioNTech released vaccination for our adolescents aged 12 to 15 years. Of course, the 16 years and up population had already been cleared for vaccine use in the with the Pfizer vaccine. The vaccine, it looks super promising and fantastic for our adolescents aged 12 to 15. When looking at their trial results, this enrolled 2,200 patients with 1-to-1 randomization, a median of 2 months of follow-up, and they had 100% vaccine efficacy for the prevention of laboratory confirmed symptomatic disease, which is excellent. And the immunobridging data was supportive. The response to neutralizing antibody was not lower than the 16 and above crew, and there was non-inferiority demonstrated, so that was excellent. Certainly the kiddos seemed to react, I think, very similar to the older kiddos and adults, with systemic symptoms being more common after the second dose, and serious adverse events were super low in both the vaccine and placebo groups, and none of those were thought to be adverse events that were outside of what we would normally see for those in the general population. So that was really excellent. And, I think we forge ahead. We have already started to vaccinate these kiddos. Our kiddos actually in the 12 to 15 age range are scheduled for vaccines next week. They are super excited about it. No, they really aren't. But that's okay. We're excited that they're going to get it. Um, this is exciting, and we definitely are forging ahead, of course, knowing that we still need a little more information on certain topics, right? So there's no current data available that assesses the hospitalization prevention in this age group, MIS-C prevention, which is going to be a sticky wicket, I think, as we move ahead, non-spike protein seroconversion, or asymptomatic infection prevention. So I think that certainly this is information that we are going to want to see as we move ahead, and we'll wait with bated breath as they do that. So, I think some closing thoughts. We definitely there has definitely been demonstrable evidence of acquisition and transmission of SARS-CoV-2 in the pediatric population. I think earlier in the pandemic, there had been a lot of discussion about, well, we don't even think that kids can get it, which I don't know where that would ever come from, but certainly lots of thoughts about that. But that throughout this pandemic has certainly been disproven. Mitigation strategies, at least for now, are still essential. And then, of course, more good quality pediatric research is needed. That's always something that has to happen in the pediatric world. And we understand that our squirts get that kind of after the adults, but it doesn't stop us from doing it. So I like this quote: if you change the beginning, you change the whole story. Of course, the COVID-19 pandemic has assuredly changed the beginning for millions of children. And we will need to think about this aftermath even long after the pandemic is gone. So with that, I will stop, and certainly would love to have any discussion. Thank you very much.
Great. Thank you, Dr. Muller. That was a really nice overview. I always learn something from our presentations here to kind of help other folks. So that's great. Now, I had a couple questions, but of course, Christian Paletta and I are on the same wavelength here as far as our questions. So I guess, do you want to just unmute and kind of go through your question and introduce yourself?
Sure. Hello, everyone. I'm Dr. Christian Paletta. I'm a clinical consultant at the Department of HHS supporting BARDA in Washington, D.C., and I've enjoyed these tremendously. So I've heard throughout the world through WHO contacts, specifically people in Scotland, England, and elsewhere, that the pediatric wards starting in November were just devoid of kids with respiratory syncytial virus. They're just empty. And obviously they're not in school, wearing masks at home. That's not going to continue moving forward, but are there lessons learned from that we can institute moving forward to kind of blunt the respiratory disease and the hospitalizations in the future? Over.
No, it's a great question, and it's one of the things that we noted, right? Like we were poised for our usual respiratory, our RSV season, our influenza season, where that's the time when we are, bursting at the seams, and it's like, you're putting kids in closets, or no, you're not really doing that, but it's like you're really like, and we didn't see any of that. And so I think this is part of, that infection control plug that I put in, that, I think we have to consider as we move ahead with the reopening of schools and sports, and everybody trying to get back to kind of what they were doing before. Like, you definitely have to consider, I don't think we ever stopped considering the potential for RSV or influenza. Even till now, when we have kiddos who come in and they are admitted with respiratory symptoms, we are still testing them for that. Now, we haven't seen much of that, but we are still doing that. I don't know what that season's going to look like as we move ahead. I don't know that anyone knows what that's going to look like. I think what I would say is we definitely have to remember that they're there. And I think that in incorporating them, kind of like testing for those respiratory viruses routinely alongside COVID-19 is going to be the way to do that. And now they have the platforms where they have the combined COVID-19, influenza, RSV, which we have used quite a bit. There's actually a comprehensive RESPAN, a respiratory virus panel that has COVID-19, influenza, RSV, human metapneumovirus, all of those. And so actually for a while when we were concerned that maybe we were going to have to cohort because the hospital was getting really full, every kiddo who came in was getting a full respiratory viral panel just so we could identify whether or not they were even asymptomatic carriers of any of those. So, you know, what is that going to look like? I don't know. I think we're all braced, right? Like, I think our knuckles are like, and what are we going to do with that? I don't know. But I do know that we have incorporated looking for them in any of our symptomatic kiddos, and then even in our asymptomatic kiddos, if in fact we are so full in the hospital that we are concerned that we may have to cohort. I don't know if there are any other pediatric folks in the audience in other institutions, what you all have done with that, but we haven't forgotten those viruses because we know that they're still here somewhere, right? And I think that the doors will open as we start to let the kids mingle again. So.
Great. Yeah, my, fortunately, we had all the extra room. We actually took over all of the pediatric wards because we had so many adult patients, and we're thankful that there wasn't RSV. And so my kind of thought process too was many of my patients are suggesting that they are going to just wear a mask in the winter time because they didn't get the flu or they didn't get respiratory viral infections that cause them to have asthma exacerbations. So it'd be interesting to see. And I think there's so much discussion about masks and can kids really wear masks and should we encourage them to wear masks in the winter? Who knows? I'm not going to go down that political rabbit hole, but I'm a big mask believer that it cut out these other infectious viruses.
Yeah, and it's true. It's hard to completely say, right? Because like for so long the kids were just home. Right, they weren't going anywhere. So like, like they didn't even have a need to mask because they were home. They weren't in school. They weren't doing all of the other things that they normally do. But I can say, I think that our babies get a little bit of a bad rap with the masks, but our bigger kids, like they tend to actually do okay with it. Like the kids go to school and now it's like commonplace. They wear their masks and we actually don't tend to have lots of issues with the kiddos being comfortable wearing the masks. Even with some of the kiddos younger than 2, they're usually going to give you a little something. And so you're not trying to do that. Even some of the 3-year-olds, our little Malachi has finally started to be okay with wearing his mask. He's 3 and he's like, okay, I want my mask now. That's okay. But before it was like, oh my gracious, what are you doing? And if you had one, it was take it off. But by and large, I think the kids really do well with the masks. And so, moving forward, I don't know that I think that we're going to get rid of the masks anytime soon. I wouldn't be surprised if we don't head into this next season, well into the season and into the respiratory viral season, still wearing masks. I wouldn't be surprised at all if that is still happening. Certainly there are situations where they don't want to do that. I think the older kiddos, the ones that are closer to the adult world, are probably the ones who want to get out of the masks more than the younger kids. So.
Great. And Dr. Pauletis is just calling it a pathogen prevention device instead of mask.
Oh, I like it.
That.
I'm liking it. That's fantastic.
Oh man. Lawrence, carry on. You have question. You want to unmute, introduce, and ask your question?
Yes. My name is Lawrence Carreon. I'm a physician assistant with the University of New Mexico. And my question is learning more and more how this particular virus is changing and mutating. I'm wondering if we have any information on the variants and their impact on the pediatric population worldwide. Are some of these variants, for example, the variant, especially now from India, the P1 and the 135 South Africa, are these having more impact and more serious infections in the pediatric population?
I think that's an excellent question. I am definitely not a variant expert by any stretch, but even trying to get that data, like I don't know that there is a ton of those. I've sat in on quite a few calls from the CDC and from Shea on the weekends. And I think they are still working through that epidemiology. I think they're still working through trying to figure out all of the different variants and which ones are variants of concern or interest, and how well that's going to fare against the vaccines, and kind of what we are seeing in the United States. I haven't come across, like, as when I look to try to see how that's impacting peds in particular, I haven't found much data that to I just haven't found much data where they are calling out variants in the pediatric world and what's happening specifically in the pediatric world. And I anticipate that's because they're still trying to even figure out what's happening in the population at large as it relates to the variant. So it's a great question. I don't have that data. I look for that data all the time, but I haven't seen much that gives us information on that. I definitely think it's a stay tuned. It's a super hot topic. And it's, I think it's part of the reason we're still in masks, even as we roll out vaccinations and more of the population is getting vaccinated, because, we still have these variants and, the questions around how well will the vaccines perform against the variants, and prevention of asymptomatic infections and carrier states with those. So it's an excellent question. I don't have the data for that. I think it's a stay tuned.
The other on the same line, early on with this infection, we were seeing that the most vulnerable people, the elderly, and as this virus circulated, we're seeing younger and younger people becoming affected. Now we have a population is being affected are the younger population. So this virus needs to go somewhere, and that's the purpose. This virus has to do this. So now we have a situation where lower and lower age individuals are becoming infected. Are we setting ourselves up to see how this is going to pan out with the younger population, less than 12, that are not yet have availability of the vaccine? So how are we looking at that aspect of having a population younger than 12 that may be more susceptible now?
Excellent question. I think the key to that is exactly what you said, right? So like it has to have somewhere to go. And as we vaccinate more and more of our population, then might we anticipate seeing more infection in the younger ages? Maybe. I don't know that it would necessarily look much different than it looks now, right? Like, even if we see more infection, does it mean that it's going to be more severe infection, or that, maybe that will have something to do with variants? I think we will have to see. But I think the biggest thing with that is exactly what you said with vaccinations. We are actually starting, there are trials that are starting with vaccinations even in the younger age groups. And, hopefully by the fall, we'll be rolling out vaccines even to the younger age groups, right? So, and that's a big push for us as we head to the the fall school session to start, we're going to want to hopefully get vaccines into the younger populations. And so we actually have a study that will hopefully, a trial that will be starting here at UNM, enrolling those younger age groups as well. So you're absolutely right. Like, could that be the case? It might be the case. We might see more of our younger kiddos having infections. Again, I don't know that it necessarily means if you're not someone who is at a little bit of a higher risk. Remember the slide we talked about with the COVID-19, those kiddos tended to be a little older, tended to have some comorbid conditions. We might see, I think more severe infection in that age range, but we're already seeing, or excuse me, in those comorbidities, but we're already seeing that anyway. So I don't know that it would necessarily change what we see with them presenting. It may increase our numbers, but we want to mitigate that by getting these kids vaccinated. And so we're definitely pushing to them performing the trials in our younger age group so we can get them vaccinated.
Thank you.
Great. And don't forget the CME link was put in the chat by our digital librarian. So please evaluate for the session. And one thing you didn't exactly, I'll have two things. I suppose, we treat the kids just like we treat the adults with the remdesivir and steroids.
Correct. So we for treatment for COVID-19, remdesivir and steroids, that is the standard of care. Now, the thing with our kiddos, though, is most of our kiddos aren't getting treated. Right? Because they're coming in with either asymptomatic infection or they're coming in with very mild infection where remdesivir and steroids are actually not recommended in those instances. So that is the mainstay of treatment for us, but it's pretty rare, honestly. Like throughout the pandemic, we haven't used much remdesivir and steroids for the treatment of COVID-19 in the pediatric world. And then for MIS-C, at least at our institution, and actually when you look at the literature in many institutions worldwide, IVIG is our standard. And because of some recent literature that steroids improves potentially outcomes, we've added steroids to that standard therapy for MIS-C. So all of those kiddos get IVIG and steroids at this point.
Great. Dr. Cairo has a question, and I haven't seen this, and so I just looked it up, about the Malaysian pediatric pneumonia due to canine coronavirus.
Oh, you'll have to educate us on that, because I have not seen that one. So would love to hear about that one. I haven't seen that and don't know anything about that. So would love to hear your thoughts on that.
Yeah. I did not, I looked it up too, but I mean, I think there are a lot of species jumping. I don't know if Dr. Cairo, if you wanted to make any comment on it or.
Just heard it today.
I know, it's like,
Fun.
we're going to be seeing new things constantly.
Yes.
Yeah, Kate Berg, is it possible to update all missed vaccines in kids when they come in for their COVID vaccine, or is that not recommended?
No, absolutely. It can happen now. Before, earlier when we, when they first rolled the vaccines out and they were still trying to get a sense of how things were going to go, they recommended not co-administering the vaccines with any other vaccines. But the latest recommendation has been changed, and they now recommend co-administration of the vaccines. And actually, partly exactly because of what you said, right? Like, especially in the pediatric world, and many, one of the unfortunate things we have seen during the pandemic is that vaccinations, routine vaccinations in the pediatric world, and maybe in the adult world too, I don't know, but in the pediatric world have fallen. And so this would be a great way to get them caught up with their vaccinations and get them protected against COVID. So now that new recommendation is out, and you absolutely can do that.
Wow. Okay. It knocked me flat, so I can't imagine getting other vaccines at the same time.
Me too.
All right. Oh yeah. Thank you, Bonnie, for putting in the novel canine coronavirus isolated from hospitalized pneumonia patient in East Malaysia, so that everybody can read about that and get scared.
Yeah.
Let's see. Liza Schomburg. Oh, as a parent, I can't send my kid out to school with so many unknowns after having the kid at home for more than a year. The only year of his life that he hasn't ever had a cold, right? So yeah, it's a tough thing to think about, sending your kids back to school or not when they've been so healthy. But
Yeah, and it's certainly scary. I can say, from our like just from a personal standpoint, like in our home, I'm actually immunocompromised, and so sending the kiddos back was a big, oh my goodness, and the three oldest have stayed home. Because by the time they opened up school for us, they were like, well, what is the point? It's like a month left. I'm not gonna go. I'm just gonna stay home and finish it. The two little girls, they actually, they're like, if you think I'm staying home through this whole pandemic, you got another thing coming, right? Like, we're not doing that. We have to go somewhere, or else we're gonna like tear the house up. That's what's gonna happen, and you're gonna want us to go somewhere else. And so, throughout the pandemic, they have actually been going to Children's Choice, and have done fantastically. They have put into play very good mitigation strategies. They're very compliant with their masks and their hand hygiene and their social distancing. We had a couple of potential scares, which were really allergies in the little kids, because I was the guinea pig and got tested for coronavirus and didn't have it. And they really have done well. We were very scared, and they actually have gone back to school, and they have done a wonderful job at the school with keeping the kids very safe. And so, it is a little bit scary to think about it, but I think with appropriate strategies in place, the kids actually really do well, and they benefit from being in the environment.
all right. Well, we're at the top of the hour, and yes, I think as schools plan to open and send kids on other trips, just remember good hand hygiene, masking up, and I will still do that despite vaccination. And thank you so
Indeed.
much for joining us, Dr. Muller. It's been great. And we'll see you guys in a couple of weeks or so. I don't have the exact topics outlined, but I've got two people that are potentially going to present, and we just got to figure out what days. All right. Thank you. Be safe. Take care. Have a great day.
Thank you.